Bismillahirrahmanirrahim. First of all, I thanks to the organizing committee, FamilyCon, for inviting me to give this talk on updated guidelines on hepatitis B. Uh, can I ask the audience, and can you show with your show of hands, that how many of you are vaccinated against hepatitis B? So it's almost, I guess, 50%. So the take-home message which I give you at the start of this talk, uh, please, if you are not vaccinated, get yourself tested and vaccinated. Because mind it that hepatitis B is a chronic ailment and we can not cure this disease. We can control this disease. To date, what medications we have, we can control this disease, we cannot cure it, but we can prevent this disease. So if you or your family members are not vaccinated, please get them vaccinated. If we talk about the disease burden, almost 296 million people are affected with hepatitis B. And the main problem with hepatitis B is that we are catering with almost 1.5 million new HBV infections. It's almost comparative to HCV, even though we have the prophylaxis for hepatitis B. And almost 1.1 million people die of hepatitis B related cirrhosis and HCC. The global perspective, if we see, we are in the intermediate zone that the incidence and prevalence of hepatitis B is 2 to 4% in Pakistan. So HPV, the major global health problem, we have 296 million cases, 3.8% of the prevalence, 1.5 million new cases, almost 0.8 million deaths due to HPV-related liver failure, cirrhosis, and HCC. And 88% of the pool is Africa, Southeast Asia, and Western Pacific. So dilemma is that only 10% of these 296 million were diagnosed and merely 2% treated. Because as you know, in hepatitis, usually we don't have any particular symptom until unless we have this cirrhosis or complication of liver disease. What is the aim of WHO? The aim of WHO is the by to 2030, we should start the reduction of this hepatitis B and C to 90%, and we should reduce the death rate to 65%. This is the natural course of the disease. Whenever we got infected, it can either present with acute hepatitis B or we can have chronic hepatitis B. So if it is persistent for less than 6 months, we say that this is acute hepatitis. If it is persistent for more than 6 months, we say that this is chronic hepatitis B. And when we give treatment, there may be partial cure, and we assess this. We will discuss in the subsequent slide that how we can test these patients. And once we have the course of the disease is that usually patients with F0 fibrosis, then if it remains there for a period of time, we can end up with this liver. So we have to prevent it so that we can manage it. If we add the medication at right time, we can prevent this part to happen. Why we need treatment in patients with hepatitis B? If you see, it is directly related with the viremia. And the incidence of cirrhosis is more as if the viral load is on the higher side. Similarly, the development of HCC is again on the higher side if we have a higher viral load. So, risk of cirrhosis and HCC, it increase to 39 folds if the viral load is more than 2000 international units. And similarly, if it is less than 2000 units, we have the low incidence of cirrhosis and HCC. What is our aim? The primary aim is treat the infected patient, and secondary aim is prevent other to get infected. So whenever we see a patient with hepatitis B, it's always recommended that the whole family should be tested for hepatitis B. If rest of the family is still not infected, we should give them prophylaxis with vaccination. And whosoever got the infection, we should assess them for the treatment. So this is the algorithm which we have whenever we see a patient with hepatitis B positive, surface antigen positive, we should look for the severity of liver disease. And the recent guidelines, they mainly emphasize on the non-invasive marker for assessment of liver. Previously, we go for the liver biopsies, but now we have this APRI score, which is very effective. We can calculate at our clinic. We need only two parameters for calculation of APRI. One is AST and the other one is platelet count. You can have this calculator easily available on the web. You add these two values and you can get the readings. If a patient have APRI score of 0.5, more than 0.5, it means he has significant fibrosis. And if it is more than 1, we say that patient is cirrhotic. So either we use APRI score or we can use elastography. This is another technique which we use. It's just like an ultrasound. We have fibroscans in which we calculate the values. If the value is more than 7, we say that this is patient have significant fibrosis, and if it is more than 12, we label that patient as cirrhotic. We have to look for ALT and HBV DNA of these patients, and we want to see the quantity of the DNA. We have to take a good medical history. We have to rule out the co-infections, diabetes, steatohepatitis, immunosuppressions, usage of the steroids for any other morbidity. We should look for the family history of liver cancer in these patients. And the general care measure is counseling and lifestyle. We have to ask them to reduce the alcohol or stop alcohol consumption. We have to guide them regarding diet so that they should reduce the patient should not be obese. And then preparation for the starting of the treatment, and we should counsel them that this is a chronic ailment. Once we start the treatment, they should not stop that treatment. Preventive measure, we should test all the family members with hepatitis B surface antigen, and whosoever is negative, we should vaccinate those patients. Okay, the treatment algorithm in the recent guideline, this is the WHO 2024 guidelines. Now, it makes us realize that we have to treat almost all the patients with hepatitis B surface antigen positive. Once you have this initial workup and you find out that patient is having significant fibrosis or cirrhosis, regardless of the viral load, we have to treat this patient. If the patient have the APRI score is less than 0.5 or elastography is less than 7, we will be going for the DNA levels. And if the DNA level is more than 2000, ALT is more than upper normal limit. Previously we thought about 2 times, 3 times raise, but nowadays the normal values, it's now the guidelines say it's up above the upper normal limit, and the upper normal limit for female is 19 and for male is 30 international units. And if this criteria fill, we will start the treatment. Or presence of any of the followings, like regardless of APRI, regardless of hepatitis B DNA level, regardless of ALT level, if patient is surface antigen positive and he has any co-infection with HIV, HDV or HCV, we have to treat. If patient have family history of liver cancer, we have to treat. Immunosuppression, any sort of patient is taking any sort of immunosuppression, regardless of B level, regardless of ALT, we have to treat. Comorbids, diabetic patients, metabolic dysfunction associated steatohepatitis, we need to give them treatment. And if there is any extrahepatic manifestation, we need to treat this patient. In the absence of access to hepatitis B assay, so this is another criteria, we need to treat these patients. So if patient is surface antigen positive and there is not affording, we have to treat regardless of any criteria. What are the treatment options? And if patient have surface antigen positive, his ALT is persistently normal, his HBV DNA is less than normal, there is no co-infection, we will not be treating only this small number of group. Rest of all, we have to treat with either with these nucleotide analogs, the tenofovir, we start with entecavir. Where these drugs are not available, we can have combinations, or we can have this tenofovir alafenamides in patients who have osteoporosis or renal impairments. How we will be monitoring these patients? So the monitoring would be every 6 months we will be have a surveillance for HCC by doing ultrasound, a good quality ultrasound and alpha fetoprotein. And we will be treatment response, we will be checking for the adherence, we will be checking for the non-invasive test, ALD and HBV DNA level on the yearly basis, and monitoring of renal functions if we have started the treatment in these patients. This is the algorithm for all the pregnant ladies and who are in the childbearing age. We will check for the surface antigen positive, and we assessment of the eligibility for antiviral prophylaxis. If patient have HBV DNA, and we will go for the testing of HBV DNA if available and the values are less than 200,000 and patient is HBe negative, no maternal prophylaxis is required. But if patient is HBe antigen positive and values are more than 200,000, we will be treating this patient. And another thing which is again simple, that if we don't have availability of DNA level, we'll be offering these patients prophylaxis for HBV. So this slide is showing comparative to the past guidelines, the recent Chinese guidelines in 2013 and the latest one, the WHO 2024 guidelines. If patient falls in the cirrhotic group, like F4 fibrosis, if he has APRI score of more than 1, or patient have significant fibrosis of 12, we will be treat this patient, we don't require PCR in these patients. If patient have significant fibrosis, the latest guideline shows that we don't require PCR, we have to treat this patient. And if patient have insignificant fibrosis, then it all depends on the viral load. If viral load is more than 200,000, we'll be treat this patient. If it is less than 200,000 and patient ALT is normal, we don't treat this patient. But if the ALT is on the higher side, again, we'll treat this patient. After seeing this complex variables, like sometimes we are assessing hepatitis B, DNA level, we talk about many a time about ALT level, upper normal limit, we talk about fibrosis. It's just like entering into the puzzle. So if you enter into the puzzle, you will be having difficulties in understanding. But with the recent guidelines, and if we compare the two guidelines which we have, recent one, Chinese guideline and the WHO guideline, we can have a straightaway pathway. So that straightaway pathway is that if you have a patient with surface antigen positive, we got the serum ALT level. If serum ALT is high, like for male it is 30, for female it is 19, we will treat this patient. If the second test ALT is normal, because this is true for our country as well. If the ALT is normal, we will look for these parameters like prevent a patient is having any receiving any chemotherapy or immunotherapy, or patient is of transplant, any extrahepatic manifestation, any co-infection, family history, comorbids, or liver status, like if the patient has significant fibrosis or cirrhosis, we'll treat this patient. Till that, these two scenarios, we don't require PCR. But if this is absent and the ALT is normal, we will be going for the PCR. And if PCR is detected, we will treat this patient. If PCR is not detected and the age value is more than 30 and patient have any co-infection with C and D, we will treat this patient. And if that is not there, we don't treat this patient, then this is, we are left with a small group of people who we have to follow 6 to 12 months. The question is why we treat in those patients who have PCR negative with normal ALT. It's about the cccDNA. We won't be going in the detailed discussion of that. So the simplified algorithm is that surface antigen positive, look for ALT, look for comorbids, and if they are not up to the mark, then go for the DNA, and if DNA is negative, then keep this patient in your follow-up. Don't need to treat this patient. Thank you for your intentions.